In this session of the Pediatric Emergency Medicine Fellow Research Design course, we will discuss how to design a diagnostic study.
This is the sixth topic in the research design course. We have discussed how to ask an answerable research question, search the medical literature, and the design of observational and interventional studies. The goals of this talk are to briefly review the difference between random and systematic error, and review the type of diagnostic studies and discuss their benefits and limitations. There are two types of error that we encounter: random error and systematic error. Random error is due to chance and is presented as a probability. It is derived from statistical analysis and expresses a p-value or a confidence interval. The correction for random error is making accurate measurements and increasing power by having an adequate sample size. In contrast, systematic error is based on biases or lack of validity in the study design. Systematic error is directional. That is, it will bias the study results in one direction or the other. The correction for systematic error is good study design. Good studies minimize bias, maximize validity, and limit systematic error. Some systematic errors are inherent to the type of study, and some can be controlled by the investigator. The term external validity indicates that it is possible to generalize from the study population to the general population. We refer to this as generalizability or applicability. The term internal validity indicates that the study measures what it intends to. Bias undermines the internal validity of a study. There are many different types of bias, and there are often many terms for the same concept. It can get confusing quickly. Types of bias can be sorted into one of three categories. These are selection bias, information bias, and confounding bias. Selection bias is the absence of comparable groups. Ask, are the groups similar in all important respects? Information bias is the incorrect determination of the exposure, outcome, or both. Ask, has information been gathered in the same way, and is the information bias random or in one direction? Confounding bias is a mixing or blurring of effects. Ask, is an extraneous factor confounding the effect? We have discussed how to format a research question with PICO and how to determine if it is a research question that is answerable with the finer criteria. We'll take a brief detour around finding a study population and variables, and we'll focus on determining which study design will best answer your research question. There are several study designs available when designing a study. Descriptive studies are typically case reports or case series. Observational studies are typically cohort studies, case control studies, or cross-sectional studies. Interventional studies are commonly called clinical trials. These include parallel group randomized clinical trials, factorial randomized clinical trials, crossover randomized clinical trials, and quasi-experimental non-randomized trials. Studies can be described by their attributes. Interventional studies determine if a causal relationship exists, while observational studies determine whether an association exists. Studies can also be described by their orientation in time. Prospective studies look forward in time, and retrospective studies look backward in time. Studies can also be descriptive or comparative. Descriptive studies analyze one study group or intervention. Comparative studies analyze more than one study group or intervention. Studies can also be described as observational or interventional. In observational studies, events are not under investigators' control. In interventional studies, investigators can control events and utilize methods to limit systematic error or bias. This is why interventional studies are considered a higher level of evidence. This slide illustrates the probabilistic approach to diagnosis. This is in contrast with the intuitive or pattern recognition approach that is quicker but at high risk of bias. We start by generating a list of likely diagnoses and estimating the relative probability of each. We often prioritize this list by organizing them into those that are common or those that are life-threatening. We then conduct investigations in an iterative fashion to increase or decrease the probability of each diagnosis on the list, and adding or removing diagnoses from the list. These investigations include elements of the history, physical examination, and diagnostic tests such as imaging or laboratory tests. Finally, we identify the most likely diagnosis. There are a number of aspects of the diagnostic process that can be studied. These include studies of differential diagnosis, in which patients with a given complaint are evaluated and ranked in order of the relative prevalence of the diseases that they have. Studies of diagnostic tests, which can focus on a variety of aspects of the test, such as properties, precision, accuracy, impact, and prognostic implications. And clinical decision rules or prediction rules, which combine many parameters into a single test or rule. A variety of study designs can be used to answer diagnostic questions. Case series can be used to answer differential diagnosis questions. Most diagnosis study designs are observational and are typically cross-sectional studies. Very rarely, there are randomized clinical trials that address diagnostic questions such as the impact of a diagnostic test on disease outcomes. Different diagnostic study questions have different outcome measures. A differential diagnosis study determines the relative prevalence of disease. Reproducibility studies assess inter-rater reliability of a diagnostic test interpretation, typically with a kappa statistic. Studies of diagnostic test accuracy report the test characteristics, which describe how well the test distinguishes between those with and without the disease. Dichotomous tests, those that can be defined as a positive test or a negative test, report sensitivity, specificity, predictive values, and likelihood ratios. Continuous tests, those that can take on a range of values, report interval likelihood ratios, or the area under the receiver operating characteristic curve. Tests used to assess prognosis utilize relative risk or hazard ratios. Studies that analyze the accuracy of diagnostic tests are a type of observational study called cross-sectional studies. Cross-sectional studies take place at a point in time. They are neither retrospective or prospective. This is a diagram of a cross-sectional study. We use the PICO format to review these studies. The PICO format for a diagnostic test accuracy study differs from that used for randomized clinical trials. The P or population is a cohort of patients with a suspected diagnosis. The I or intervention is the diagnostic test. The C or control may be called the gold, reference, or criterion standard, and the O for outcome is the test characteristics of the diagnostic test, including sensitivity, specificity, predictive values, and likelihood ratios. This study was conducted to analyze the accuracy of a non-contrast CT scan of the abdomen and pelvis and the identification of appendicitis. The P is for population, is primarily adult patients with suspected appendicitis. The I for intervention is a non-contrast CT scan of the abdomen and pelvis. The C for criterion standard is the operative report, pathology report, or clinical follow-up. And the O for outcome is the test characteristics of the non-contrast CT scan. This is a diagram of a case control study of diagnostic test accuracy. Those with the disease, the cases, and those without the disease, the controls, are identified. Case control studies, by definition, are retrospective and are at risk for recall or record bias. The diagnostic test is applied to both the cases and the controls to determine the test characteristics. This is an example of a case control study used to assess diagnostic test accuracy. Those with streptococcal pneumonia, bacteremia, the cases, and those without streptococcal pneumonia, bacteremia, the controls, were identified. The diagnostic test, a urine streptococcal pneumonia assay, was applied to those with and without strep pneumonia to determine the test characteristics. Case control studies are good for rare diagnoses when a very large sample size would be required to reproduce the disease spectrum. For example, the first iteration of the PICO cervical spine injury rule used a case control design due to the rarity of cervical spine injury in children. They included 540 cases with cervical spine injury and matching controls. With a rate of cervical spine injury of 1 to 2%, a cohort study would require a sample size of 27,000 to 54,000 patients to include 540 patients with cervical spine injury. The cases are those with a rare disease. The controls are those without the disease. Ideally, these controls should be matched to cases for important confounding variables. Propensity matching is often used for this purpose in observational studies. The outcomes in a case-controlled diagnostic study are sensitivity, calculated in the cases, and specificity, calculated in the controls. In a case-control study, the investigator determines the ratio of cases to control. The prevalence of the disease in the study population and predictive values cannot be calculated in a case-control study. The study cohort of patients with suspected disease should reflect the characteristics of the population of interest. For example, the pediatric literature on children with suspected pneumonia has a positive chest X-ray rate of approximately 20%. If your study sample has an X-ray positivity rate of 50%, something is different about them that needs to be addressed before the results can be generalized to the general population. For diagnostic test accuracy studies, spectrum bias may affect test performance when there is a spectrum of disease. For example, ultrasound for appendicitis will have a higher sensitivity in a population with a high rate of perforation with abscess than in a population with a high rate of distal tip appendicitis. Blinding reduces ascertainment bias. Those assessing the diagnostic test should be blinded to the reference standard, and those assessing the reference standard should be blinded to the test. Blinding may not be essential if a reference standard is objective. For example, a reference standard of a positive blood culture is objective. Knowledge of the test result, the white blood cell count or CRP, would not affect the interpretation of the outcome. Blinding should be applied to all involved in the study. Double blinding is not sufficient. This includes patients, parents, the treatment team, investigators, outcome assessors, and data analysts. The reference standard is also called the gold or criterion standard. The reference standard should be the definitive answer for disease identification. The same reference standard should be applied to all patients. However, this is not always possible for ethical or feasibility reasons. For example, all patients with suspected appendicitis cannot be taken to the operating room. Instead, a surrogate measure, such as clinical follow-up, is often used. In the PICO studies, patients at high risk of pulmonary embolism underwent a pulmonary angiogram, while those at low risk or intermediate risk of pulmonary embolism underwent a ventilation perfusion scan. Since the two reference standards have differing abilities to identify a pulmonary embolism, this can lead to verification or workup bias. After assessing disease probability in my patient and deciding which test to order, I find it helpful to think about the specific results that I need to make clinical decisions about disease probability in my patient. The two questions are: what is the likelihood of disease if the test is positive? This is the post-test probability of disease for a positive test. And what is the likelihood of disease if the test is negative? This is the post-test probability of disease for a negative test. It is important to understand the impact of the answers to these questions on the management of the patient before ordering the test. We'll keep these two questions in mind as we review the test characteristics. Essentially, we use tests with a positive and negative outcome to allow us to stratify the patient into high risk and low risk categories. The test characteristics, sensitivity, specificity, predictive values, and likelihood ratios help to assess how well the diagnostic test accomplishes this stratification. This is a standard 2x2 table. The disease goes on the top in the columns and is divided into those with disease and those without disease based on the reference standard. The test goes on the sides in the rows and is divided into those with a positive test result and those with a negative test result. Notice that I didn't use the terms true positive, true negative, false positive, and false negative. That is intentional. I find that they add more confusion than clarity to the process, so I try to avoid them whenever possible. This is the data from the non-contrast CT appendicitis study. After adding the marginal totals, the first thing I like to do is calculate the disease prevalence. In this case, it is the percentage of the total patients that had appendicitis. This is 115 divided by 300, or 38%. Notice that prevalence is calculated horizontally. This is important. Test characteristics that are calculated horizontally, such as predictive values, would be affected by changes in prevalence. Test characteristics that are calculated vertically, like sensitivity and specificity, will not be affected by changes in prevalence. In the appendicitis study, the sensitivity is defined as a percentage of patients with appendicitis that had a positive CT scan. In this study, it is 110 out of 115, or 96%. Note that sensitivity is calculated vertically and is therefore not affected by changes in prevalence. In the appendicitis study, specificity is defined as the percentage of the patients without appendicitis that had a negative CT scan. In this study, it is 181 out of 185, or 98%. Again, note that specificity is calculated vertically and is therefore not affected by changes in prevalence. It is helpful to practice using the test characteristics in a sentence using the study parameters. For sensitivity, 96% of the patients with appendicitis had a positive CT scan. For specificity, 98% of the patients without appendicitis had a negative scan. Remember the two questions that I posed at the beginning about post-test probability? What is the post-test probability of my patient having appendicitis if the CT scan is positive? And what is the post-test probability of my patient having appendicitis if the CT scan is negative? Unfortunately, sensitivity and specificity are disease-oriented and not patient-oriented. You cannot determine the post-test probability of disease from sensitivity and specificity. Let's calculate the study predictive values. The predictive value of a positive test is a percentage of patients with a positive CT scan that had appendicitis. In this study, it is 110 out of 114, or 96%. Note that predictive values are calculated horizontally, so they will change as prevalence changes. The predictive value of a negative test is a percentage of patients with a negative CT that did not have appendicitis. In this study, it is 181 out of 186, or 97%. Again, note that predictive values are calculated horizontally, so will change if prevalence changes. Predictive values are patient-oriented. They provide post-test probability of disease, but only for those with the pre-test probability or prevalence in the study. The predictive value of a positive test indicates the post-test probability of having appendicitis in those with a positive CT scan. This is 96%. The predictive value of a negative test indicates the post-test probability of not having appendicitis in those with a negative CT scan. This is 97%. We want to know the post-test probability of having appendicitis if the CT scan is negative. To get the post-test probability of having appendicitis if the CT scan is negative, subtract the predictive value of a negative test from 1 or 100%. In this case, the post-test probability of having appendicitis if the CT scan is negative is 1 minus 0.97, which equals 0.03 or 3%, or 100 minus 97%, which equals 3%. This makes sense. If you have a 90% chance of not having appendicitis if the CT scan is negative, then you have a 3% chance of having appendicitis if the CT scan is negative. The predictive values allow us to stratify a patient with a 38% pretest probability of appendicitis, which is the study prevalence, into a high-risk group and a low-risk group. If the CT scan is positive, the post-test probability of appendicitis is 96%. This is approximately a 2.5-fold increase from pretest probability to post-test probability. If the CT scan is negative, the post-test probability of appendicitis is 3%. This is approximately a 13-fold decrease from pretest probability to post-test probability. In this study, a negative test, a 13-fold decrease, changes pretest probability to post-test probability more than that in a positive test, a 2.5-fold increase. Unfortunately, predictive values only apply to patients with a 38% pretest probability of appendicitis. The predictive values can't be used to determine the post-test probability of appendicitis in a patient who has a pretest probability, for example, of 20%. Finally, we'll look at the likelihood ratio of a positive test and the likelihood ratio of a negative test. I prefer the term likelihood ratio of a positive test rather than positive likelihood ratio, and prefer the term likelihood ratio of a negative test rather than negative likelihood ratio. The likelihood ratio of a positive test is how many times more likely it is to test positive if you have the disease compared to not having disease. The likelihood ratio of a negative test is how much more likely it is to test negative if you have the disease compared to not having the disease. These formulas translate into the same formulas that include sensitivity and specificity, but provide a better understanding of how to interpret a likelihood ratio. A likelihood ratio of a positive test is the likelihood of testing positive in those with disease divided by the likelihood of testing positive in those without disease. This simplifies to test positive of disease positive divided by test positive of disease negative. Notice that the positive test is in the numerator and the denominator. The likelihood ratio of a negative test is the likelihood of testing negative in those with disease divided by the likelihood of testing negative in those without disease. This simplifies to test negative of disease positive divided by the test negative of disease negative. Notice that the negative test is in the numerator and denominator. The formulas in the boxes are the ones that I prefer. Here are the CT study likelihood ratios. The likelihood ratio of a positive test is the likelihood of a positive CT scan if you have appendicitis divided by the likelihood of a positive CT scan if you don't have appendicitis. The likelihood ratio of a positive test is 45. The likelihood ratio of a negative test is the likelihood of having a negative CT scan if you have appendicitis divided by the likelihood of having a negative CT scan if you don't have appendicitis. The likelihood ratio of a negative test is 0.04. The likelihood ratio of a positive test indicates that the patient is 45 times more likely with a positive CT scan to have appendicitis than not have appendicitis. The likelihood ratio of a negative test indicates that the patient is 0.04 times more likely with a negative CT scan to have appendicitis than not have appendicitis. I understand what 40 times more likely means, but it's harder to understand what 0.04 times more likely means. Shouldn't a negative test mean that there's less likelihood of disease? I get around this problem by taking the inverse of the likelihood ratio of a negative test. In this case, it is 1 divided by 0.04 and is equal to 25. 0.04 times more likely becomes 25 times less likely. I can now directly compare the two likelihood ratios. A likelihood ratio of 45 is greater than a likelihood ratio of 25, so the CT scan is a better test when it is positive than when it is negative. That is, there is a bigger change from pretest probability to posttest probability if the CT scan is positive than if the CT scan is negative. Likelihood ratios are patient-oriented. You can calculate the posttest probability of disease based on the individual patient's pretest probability. Likelihood ratios indicate the degree of change in disease likelihood from pretest to posttest probability. A likelihood ratio less than 1 indicates that the posttest probability is less than the pretest probability. A likelihood ratio equals to 1 indicates that the pretest probability is equal to the posttest probability. And a likelihood ratio greater than 1 indicates that the posttest probability is greater than the pretest probability. Unfortunately, likelihood ratios are an odds and not a probability, and need to be converted into posttest probability with a likelihood ratio nomogram or a calculator. All three types of test characteristics have some limitations. Sensitivity and specificity are disease-oriented and not patient-oriented, so that you can't determine a patient's posttest probability of disease from them. Predictive values are patient-oriented, but are affected by prevalence and don't give you the posttest probability of disease for your specific patient. Likelihood ratios are odds and not probability, so they need to be converted using the nomogram or a calculator to give the posttest probability of disease in your patient. There are two ways to determine the test performance of a diagnostic test or rule that can take on more than two values. The first is by using interval likelihood ratios. This is done by creating ordinal categories of the test result. This table presents data from a study assessing the accuracy of the white blood cell count in the diagnosis of appendicitis. The white blood cell count was categorized into 5 ordinal intervals. The intervals chosen should be based on the data and not arbitrarily assigned. Remembering that a likelihood ratio with a value of less than 1 indicates a decreased risk of the outcome, we can see that a white blood cell count of less than 8, a white blood cell count from 8 to 10, and a white blood cell count from 10 to 12 are associated with a decreased likelihood of appendicitis. The likelihood ratio of a white blood cell count from 12 to 15 and a white blood cell count of greater than or equal to 15 indicate an increased likelihood of appendicitis. The second way to determine the accuracy of diagnostic tests that can take on more than two outcomes is by using receiver operating characteristics curves. Receiver operating characteristics curves can be used for an ordinal test result, such as the pediatric appendicitis score, or for continuous test results, such as blood pressure, to assess test accuracy and select an optimal test cutoff. The y-axis is sensitivity, or the true positive rate. The x-axis is 1 minus specificity, or the false positive rate. Test accuracy is assessed by the area under the curve, or AUC. The dashed line indicates a test with an equal chance of a true positive and a false positive. This is a useless test, equivalent to flipping a coin. The test cutoff is chosen based on the desired sensitivity and specificity. We can also compare the accuracy of two tests by plotting a second ROC curve. In this example, there is a white blood cell curve and a C-reactive protein curve. We see that the area under the curve for CRP is 0.9, and it is greater than the area under the curve for white blood cell count, which is 0.75. We can conclude that CRP is a more accurate diagnostic test for appendicitis than the white blood cell count. When designing a diagnostic test accuracy study, it is important to think about the risk of bias criteria that will be used to assess it. The risk of bias criteria for a study of diagnostic test accuracy from the user's guide to the medical literature include: did participating patients present a diagnostic dilemma? Did investigators compare the test to the appropriate independent reference standard? Were those interpreting the test and reference standard blinded to other results? And did investigators perform the same reference standard to all patients regardless of the results of the test under investigation? So, what is a clinical decision rule? A clinical decision rule is a group of predictors used to make clinical decisions. They may include elements of the history, physical examination, and basic labs. In essence, the parameters that make up the rule can be thought of as a diagnostic test. Examples of clinical decision rules include the Ottawa ankle rules and the PICO and head trauma decision rules. Clinical prediction rules assess the likelihood of a future clinical event. Clinical decision rules direct a clinician to a specific course of action. These terms are often used interchangeably. When would a clinical decision rule be helpful? I think of many of the diagnostic situations we find ourselves in as a search for a needle in a haystack. It is often a common presentation, such as head trauma, where there's a really low risk of something very bad happening, such as an intracranial hemorrhage requiring neurosurgical intervention. There are many factors that can be considered in the diagnostic process, such as the mechanism of injury, the patient's symptoms, and physical examination findings. There's also practice variation of who undergoes testing, so there is the potential to reduce resource utilization, such as CT scans, if we can identify those at low risk for the outcome without missing those with the outcome. The goals of a clinical decision rule are to correctly identify patients at high risk of the outcome, to correctly identify patients at low risk of the outcome to reduce resource utilization in the low risk patients. In general, higher sensitivity is prioritized over high specificity in the derivation of a clinical decision rule. This is because missing a serious outcome is considered less desirable than reducing resource utilization. The aim is to derive a rule that is generalizable to the population at risk for the outcome, a rule that makes sense, is reproducible, and easy to apply. We reviewed the PICO format for a diagnostic test accuracy study earlier. The P is for population is a cohort of patients with a suspected diagnosis. The I or intervention is the diagnostic test. The C or control may be called the criterion, reference, or gold standard. And the O for outcome is the test characteristics. The PICO question for a clinical decision rule is very similar to that of a diagnostic test study. The P or population is a cohort of patients with a suspected diagnosis. The I or intervention is the group of significant predictors or rule parameters rather than a single diagnostic test. The C or control may be called the criterion, reference, or gold standard, and the O or outcome is the rule characteristics rather than test characteristics. The PICO and head trauma study is an example of a clinical decision rule. The population is pediatric patients less than 18 years old with non-trivial blunt head trauma and a Glasgow Coma scale of at least 14. The intervention is the rule parameters, which consist of elements of the mechanism of injury, history, and physical examination. The control was a head CT or clinical follow-up, and the outcome is the rule characteristics. There are 4 stages of development of a clinical decision rule. Stage 4 is the derivation of the rule. The derivation is the identification of factors predictive of the outcome. Stage 4 rules have not been validated or validated only in split samples in large retrospective databases or by statistical techniques. Validation is evidence that the derivation results are reproducible. Validation can be broad or narrow. Stage 3 is narrow validation of the rule in one narrow prospective example. That is the validation in a similar setting or population. Stage 2 is broad validation. The rule shows accuracy either in one large prospective multi-center study, including a broad spectrum of patients and clinicians, or validation in several smaller settings that differ from one another. Stage 1 is an impact analysis that indicates a change in clinician behavior with beneficial consequences. The level of rule development corresponds to the rule's applicability. Level 1 rules have been derived, validated broadly, and have an impact analysis. These are rules that can be used in a wide variety of settings with confidence that they can change clinician behavior and improve patient outcomes. Level 2 rules have been derived and validated broadly. These are rules that can be used in various settings with confidence in their accuracy. Level 3 rules have been derived and validated narrowly. These are rules that clinicians may consider using with caution and only if the patients in the study are those in your clinical setting. Level 4 rules have been derived only. These are rules that need further evaluation before they can be applied clinically. When designing a clinical decision rule, it is important to think about the risk of bias criteria that will be used to assess it. The risk of bias criteria for the derivation of a clinical decision rule from the user's guide to the medical literature include: were all important predictors included in the derivation process? Were all important predictors present in a significant proportion of the study population? Were the outcome events and predictors clearly defined? Were those assessing the outcome event blinded to the presence of the predictor? And were those assessing the presence of the predictor blinded to the outcome event? And was the sample size adequate, including an adequate number of outcome events? The risk of bias criteria for the validation of a clinical decision rule from the user's guide to the medical literature include: were the patients chosen in an unbiased fashion, and do they represent a wide spectrum of severity of disease? Was there a blinded assessment of the criterion standard for all patients? Was there an explicit and accurate interpretation of the predictor values and the actual rule without knowledge of the outcome? And was there 100% follow-up of those enrolled? Differential diagnosis studies start with a cohort of patients with a suspected disease who then undergo a diagnostic evaluation to determine the relative prevalence of diseases in the differential diagnosis. This study enrolled pediatric patients with chest pain who underwent a standardized history and physical examination and further testing at clinician discretion. The differential diagnosis for pediatric chest pain is listed in the order of relative prevalence. These are the risk of bias questions for a differential diagnosis study from the user's guide to the medical literature. Did the study patients represent the full spectrum of disease with this clinical problem? And was the diagnostic evaluation definitive? Reproducibility for a diagnostic test refers to consistency in the interpretation of a diagnostic test. This is very important for subjective diagnostic tests. Lack of reproducibility can be due to level of training or experience, specialty differences, or institutional differences. Intra-rater reliability refers to more than one observation made by one interpreter. Inter-rater reliability refers to more than one observation made by more than one interpreter. Studies of reproducibility do not require a gold standard, and typically the results are a kappa statistic. This is a diagram of a study of diagnostic test reproducibility. A diagnostic test is applied to a cohort of patients with suspected disease. Observers individually interpret the diagnostic test, and their level of agreement is assessed. There is no comparison of the test to a reference standard in a diagnostic test reproducibility study. Notice the absence of the C in the PICO bar. This study assessed the inter-observer reliability of chest X-ray interpretation by 2 pediatric radiologists in a population of patients with suspected community-acquired pneumonia. Reproducibility is typically measured by the kappa statistic. The easiest way to understand kappa is to think of it as the level of agreement beyond chance. Kappa provides a quantitative measure of association, which is standardized to take on a value between 0 and 1. A kappa less than 0.3 indicates a poor level of agreement beyond chance. A kappa between 0.3 and 0.6 indicates a moderate level of agreement beyond chance. And a kappa greater than 0.6 indicates a good level of agreement beyond chance. It is important to remember that kappa indicates agreement. It does not indicate that the agreement is correct. Rarely, randomized clinical trials can be used to study diagnostic test impact. Patients with a suspected diagnosis are randomized either to the test compared to no test or the test compared to another test, and outcomes are measured. This is a study that assessed the impact of a sonography followed by CT as necessary protocol. Patients with suspected appendicitis were randomized to a sonography CT protocol or no protocol. The outcomes were the rates of perforation, negative laparotomy, and admission. When designing a study, it is helpful to review guidelines for that type of study. This is a partial list of study designs available at the Equator Network website. If you are designing a diagnostic test accuracy study, the STARD, or Standards on Reporting on Diagnostic Accuracy Studies, should be reviewed prior to your study design. In summary, studies of diagnosis and diagnostic tests, including clinical decision rules, address a variety of questions. These can include test or rule accuracy, relative prevalence of disease for differential diagnosis, reproducibility for test interpretation, the impact of the test on outcomes, and the prognostic implications of a test. A variety of study designs can be used to answer these questions. On to our questions. What aspect of a diagnostic test may be studied? Precision, accuracy, impact of test utilization on outcomes, prognosis of disease based on test result, or all of the above? The answer is E, all of the above. Many aspects of the diagnostic test can be studied. The most common is diagnostic test accuracy. What study designs can be used to study diagnosis questions? Cross-sectional, case control, randomized controlled trial, prospective cohort, or all of the above? The answer again is E, all of the above. There are many diagnosis questions that can be answered by a variety of study designs. Cross-sectional studies can be used to assess diagnostic test accuracy. Case control studies can be used to assess diagnostic accuracy when a disease outcome is rare. Randomized control trials can be used to test the impact of a diagnostic test on outcomes, and prospective cohort studies can be used to determine if a diagnostic test has prognostic significance. Blinding of the test assessor to the outcome and of the outcome assessor to the test results is always required in a study of diagnostic test accuracy. True or false? The answer is B, false. Blinding of the assessor to the outcome and the outcome assessor to the test is used in most diagnostic test studies to reduce the risk of ascertainment bias. This is particularly true when the outcome is subjective. For example, knowledge of a physical examination finding may bias lung ultrasound interpretation. When an outcome is objective, blinding may not be required. For example, it would be very difficult to bias an outcome of bacteremia, a positive blood culture, by awareness of the white blood cell count. A clinical decision rule was derived at a single institution, validated in a multi-center trial, and shown in additional studies to reduce resource utilization to the degree identified by the original study. What stage of development is this rule? 1, 2, 3, 4, or 5? The answer is A. It is a stage 1 clinical decision rule. It has gone through derivation, a broad validation, and an impact analysis confirming the initial results. Stage 2 is a broad validation, Stage 3 is a narrow validation, Stage 4 is derivation only, and Stage 5 does not exist. A clinical decision rule for appendicitis was derived at a single institution and validated in the same split data sample. How can this rule be applied? Needs further evaluation before it can be applied clinically, can be used with caution if your patients are like the study population, can be used with confidence in various settings, or can be used in confidence in various settings that it can change physician behavior and improve patient outcomes. The answer is A. The rule needs further evaluation before it can be applied clinically. The applicability of a clinical decision rule is dependent on the stage of development. The clinical decision rule described in this question is a Stage 4 clinical decision rule. It has been derived only. Stage 4 rules should not be used until they are validated. Internal validation in the derivation sample does not constitute either broad or narrow validation. Now that we are finished with the design of observational studies, interventional studies, and diagnostic studies, we'll move on to selecting and defining subjects and variables in the next session of the research design course.